Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. Today is one of your question and answer sessions, but these questions are exclusively from the weekly newsletter. I get asked thousands of questions every week, and it's one of the things that I love, connecting with this community and this audience and helping you really get the answers that you're looking for. Thousands a week. That is telling you just how hard it is to get accurate health information about your fertility and your body. And I'm so glad that you're here, and we're going to go into some of these questions. If you would like to subscribe to the newsletter, you can always sign up at nataliecrawfordmd.com/newsletter. That's going to be a way where you can see weekly updates, special offers, some of my favorite recipes, products, and also have opportunities like this, which is getting better access or having a higher chance of having your question asked. So we are going to jump in and go through these. We do answer questions on Instagram and at the end of regular podcast episodes, and those questions can be asked at nataliecrawfordmd on Instagram every Monday. You can also call and leave a voicemail. The voicemail number is 657-229-3672. Again, that is 657-229-3672. Really excited to have some podcast changes coming up. So just want to say huge thanks of appreciation for you being here, and let's learn together. All right, we're going to jump on in, and I'm going to be reading these questions out loud. I really love to group Q&A episodes into themes for easier listening, but that's not today. Today we are just going random and I'm going down the list. So here we go. Does having recurrent pregnancy loss automatically put me in the high risk category once I have a viable or full-term pregnancy? This is a good question. If you're new, it's near and dear to my heart, as I had 4 pregnancy losses before I had my 2 kids. So I know how hard it is, how heartbreaking it is, and how you're trying to think about everything, because once you've been in such an uncontrollable situation, you're really looking for what you can control. The short answer is no. Just having RPL does not mean that you have a high-risk pregnancy by any means. The longer answer is always, it depends. Do we know why you had recurrent pregnancy loss? Is it due to a clotting disorder? Is it due to something genetic? Is there some medical problem? Those things might make you higher risk. But just having a history of recurrent pregnancy loss itself does not put you at higher risk during the pregnancy. What is the appropriate diet for conception? Is there anything specific to avoid broadly? Well, I do love diet questions, and they're hard. In general, this is what I tell my patients and how I describe this. This is not new or shocking information. You know this. Eating more fruits and vegetables, eating real foods, having less processed foods, having less sugar, that's always going to err on the side of good. Overall, a more Mediterranean-style diet, meaning accepting healthy fats, avocados, olive oil, nuts, those things are all good and fine for you. We have to remember that a lot of meats are processed, and those we should not be having. If you're a meat eater, that's okay. No data supports that you have to totally avoid meat. However, when you look at quartile data, having less meat and being in the lowest group showed improvement in certain categories, such as embryo development or ovulation if you have PCOS. So this is the diet that I recommend to my average patient who walks in the door and is an omnivore, like a normal eater. Meatless Monday. There you go. You can eat whatever you want, just no meat on Monday. The other days of the week, have meat 1 serving a day. And for the purposes of this discussion, I'm not counting eggs as meat, and dairy is its own category, so cheese, things like that. So meat 1 serving a day, the other days of the week, and red meat only once. We're going to avoid our processed meats, so sausage, bacon, toodaloo. We're going to avoid processed, refined carbohydrates, sugars, foods. Things that when you look at the back are just not real ingredients. So a lot of these are your bars that you might eat and random chips and snacks and things that are put together like that. desserts in general, added sugar, added sweets, soda, even diet soda. There's no need for that, especially not on a regular daily basis. Lots of fruits and veggies, no limit. Anybody who ever tells me that fruit should not be consumed, absolutely not. Fruit is one of the most natural things, tons of good nutrients in fruit. And carbohydrates and dairy. So in general, unless you're me and you have celiac, which you're probably not, whole grain foods. So whole grain carbs have a lot of fiber. They are complex. That can be an antioxidant-like property. Absolutely. But not all carbohydrates are created equal. So definitely leaning towards some that are better for you. So your quinoa, your brown rice over your white bread. Also, when it comes to dairy, I recommend the full fat, like the real stuff, not anything that's skim or processed. Just think about it. If you're taking fat out of milk, you're usually adding something else to keep it as milk consistency. So if you want cream in your coffee, add cream to your coffee. Don't have something more artificial feeling like that is better for you. And overall, you have to live your life. If you eat a really healthy, whole foods-based diet, low in processed foods, low in added sugar, then that's going to give you the flexibility to enjoy your life and have cake on your birthday and celebrate without thinking that it's going to set you off. I don't ever want anybody to view this as a diet. I'm putting that in quotes. It's not a diet. A diet is something you do for a period of time. This is a healthier way of eating, a better way of treating your body. You're preparing your body to carry a baby and grow a human. And so let's treat it with kindness and respect and nourishing foods so that we have all the nutrients we need to do so. Quick note, that is the average diet for conception for the average person. Certainly if you're having infertility, if we're worried about inflammatory diseases or autoimmune disease, there can be certain modifications for you. But if we're just talking about general fertility diet for conception, that is my recommendation. All right, the next question is a little bit more detailed about IVF, and I am not giving second opinions, meaning I don't know your full story. I do not have your records in front of me. A lot of times the answer is in some detail so small, you're not telling it in a question. So I'm going to summarize this to try to get to the best way possible. In general, this is a 36-year-old who had a miscarriage at age 35. Since then, has undergone IVF and has 5 genetically normal embryos. Has now had 3 embryo transfers that haven't worked, a variety of different protocols, has had a hysteroscopy with a polyp removed, and essentially is just asking, I'm not sure what to do. So the take home for me and big picture, what I think about when we are in the place of recurrent implantation failure. So that's what this is. Recurrent implantation failure is ultimately really not that common, meaning the definition is based on having 3 euploid, so genetically normal embryos, each transferred in different independent cycles and not having a pregnancy. 95% of people will achieve success within those 3 transfers. So this is only about 5% of all people who go through IVF. I'm going to run down what my brain thinks about. And some of these things this person has told me has been done, but just overall. Number 1, it could be bad odds. Now, we only lean on this usually later, but in general, if I say one embryo has a 65% chance of success, yes, 95% of people will achieve success in the first 3, but some people, it just takes more embryos. It's just rolling the dice badly. We have to get there. But I don't like to just lean on that without further investigation. Number 2, uterine cavity fallopian tube evaluation. So hysteroscopy is the gold standard. That's camera inside the uterus to look around. Things like a polyp can impact implantation. So can scar tissue, uterine septums. You can also do a saline sonogram inside the office, which is similar. It's where you put a catheter in the cervix and you inject saline and you watch with ultrasound. And essentially a saline sonogram, to me, it's a screening test. So it's either perfect, yay, or it's not perfect. And anything not perfect gets you a hysteroscopy to go and evaluate further. We also need to evaluate the fallopian tubes because one thing is that if you have what's called a hydrosalpinx, which is a blocked and dilated fallopian tube that is connecting to the uterine cavity, that can cause some toxins, some inflammation inside the uterus itself. And having an embryo transfer in the presence of a hydrosalpinx is associated with a 50% decrease in pregnancy rates. So this is a scenario when you find a hydrosalpinx, you actually have to get it surgically removed or at least blocked so that the toxic fluid inside that dilated tube can't leak back into the uterine cavity. You would be shocked how many people come to me and they've had no evaluation of the inside of the uterus, no evaluation of the fallopian tubes. Mind-blowing. None at all, none at all. So always think about anatomy. Next, with the context of having a miscarriage also, and depending on if these were just negative or if any of them were chemical pregnancies, I always think about some things that are more traditionally associated with recurrent pregnancy loss, but I often think about this blood work as well, which can be for clotting disorders and see if you have any thyroid disease, specifically autoimmune thyroid disease, by checking antibodies. So any autoimmune thyroid disease, what is your thyroid hormone status? Do you have any clotting disorders such as factor V Leiden or antiphospholipid antibody syndrome? Now, again, you could easily say that you haven't lost anything and so you shouldn't check that. I'm just rattling off lists of things you could consider depending on the entirety of the clinical situation. You could consider thinking about endometrial inflammation, and that's called endometritis. So let's just differentiate between endometritis and endometriosis. Endometritis is diagnosed with a biopsy of the uterus where you're specifically looking for cells that are showing some inflammatory markers. Endometritis is treated with antibiotics. Studies have not shown that treating and rebiopsying has any higher chance of success than just empirically treating somebody with antibiotics. Everybody has a different style. I tend to be in the camp of 2 weeks of doxycycline, easier than biopsying inside your uterus. So I tend to do a prolonged course of antibiotics, but some people might recommend biopsying and then seeing what that biopsy sample shows. Another thing to think about is endometrial receptivity, and that's an ERA. There's a lot of things to say about an ERA test because the idea here, as we went through, we've got genetically normal embryos. Why is the success rate only 65%? Must be the uterus for the other 1/3. And there was this huge shift in everybody blaming the uterus and doing this biopsy called the endometrial receptivity test, which in essence, you would go through an entire fake cycle, get medications, get the lining ready, take progesterone, and then you would do a biopsy sample and send off the uterine lining so that you could look at the expression of the genes for estrogen and progesterone to see if that looked like it was the perfect day for implantation. And if not, it was recommending more progesterone most of the time, but occasionally would recommend less. Now, the ERA went from you should evaluate this for patients with recurrent implantation failure into being so over-promoted and overdone. You had one failure, let's do it. You just have one embryo, let's do it. And then a study came out showing us that success rates for the ERA test in people who did not have recurrent pregnancy loss or recurrent implantation failure actually were lower than people who didn't even have the ERA. So a prime example of where technology can roll out well before all the evidence, and every single thing that might be offered is not always every single thing that you should do. But this is a circumstance where I would discuss and talk about an ERA test. It would honestly depend on the full situation for me. Now, another thing is to think about, do you have any autoimmune disease? Do you have any signs or symptoms of endometriosis? Any signs or symptoms of adenomyosis? Because those cycles can, and in my opinion, should be treated with Lupron. And there's a few different ways to get there, whether it's Lupron the whole time or Lupron before, for longer, for shorter. But those are cycles where I don't prefer a modified natural where you're growing an egg and that's growing the lining. So thinking about, has endo been diagnosed? Are there any signs of it? Any signs of adeno? Talking through how Lupron can help with the inflammation and the suppression of that disease. Talking about some of the longer or more extended protocols that exist. That is something that I have had great success with in this circumstance, especially if there are any potential autoimmune disease in your family, any pain with your periods, pain with intercourse, GI symptoms when you're on your period, or any signs or symptoms of adenomyosis as well. So definitely something to ask and to think about. especially when we're choosing the protocol. So we'll say protocol changes. And then there's add-ons, and there's a whole lot of different ones, right? Adding on aspirin, adding on steroids longer, antibiotics, adding the antibiotics longer. Many of those I feel like are very low risk, possible benefit. There's others that could be high risk and high expense and limited benefit without a known diagnosis. Things like IVIG and these huge steroid regimens. There are some patients who need that. Not everybody's created equal. But so my bigger thought is sit down with your doctor, have a WTF appointment, really dive through your whole history. Make sure they know everything, your family history, are there any autoimmune disease, any chronic disease at all? What are your symptoms that you might not even think are related? And really talk through, has all the blood work been tested? Have you anatomy checked everything? What protocols have you done? What add-ons might make sense at this time? Overall, sending you lots of love. Most people will still have success with that fourth transfer, no matter what you do, is my opinion. But I know that this is such a stressful time. So make sure that you're getting all the information you need. And this is also a time where you could consider a second opinion. I promise your doctor is not going to hold it against you. You'll have to send off all your records because you have to give the new care team all the info they need. And they may not want to dive into all of it with you if you 100% are never going to transfer care to them, because you can't come to me and get my opinion and then take it back to your doctor and say, well, Dr. Crawford said we should do this protocol. You don't want a doctor managing a protocol they don't want, or they don't know, or they're not as familiar with. But you might really resonate with that new doctor, and maybe switching care is the right thing for you. All right, next question from the newsletter is it worth taking CoQ10 if you're just starting to try to conceive? If so, how much should you take, and does it need to be in the form of Ubiquinol? So CoQ10 has gotten a lot of press and attention lately across many different areas of medicine. So across aging, longevity, cardiovascular, and fertility. If we want to think about what CoQ10 is, it is a coenzyme that helps your body utilize vitamin E, so it's an antioxidant. And one thing that it helps is in the production of energy. If we think about the cell, your whole body is made of cells. Inside the cell is mitochondria. And if you remember back to biology, the mitochondria are the powerhouse of the cell. That's what generates energy. So CoQ10 can help the cell utilize energy and more effectively. Now, why has it gotten attention and what does it mean? CoQ10 is found naturally in some foods. So especially in some different like fatty foods, some fats, some oils, some nuts, some legumes, meat products, some vegetables. So it can be found in a variety of different food sources, but it can also be found in a supplement form. And it's interesting because it is one of the supplements that has really good absorption across both if you take it via food or via supplement. Why are we talking about it now? Why are you seeing it added to your prenatal? Well, if we think about that mitochondria being a powerhouse, like a power plant or an engine, the older it is going to break down. It's going to wear, and it's not going to function as effectively and as efficiently as it did previously. And the same thing starts to happen inside of our cells as we get older. And that's one thing that contributes to aging. Why do humans age? Your cells start to not function as good as they used to. They don't make as much energy. They don't heal and repair quite as well, and we age. When it comes to eggs and sperm specifically, the mitochondria, and we just think about the entire function of getting to the stage of being a gamete, is to have the right number of chromosomes. So mitochondria are really important when the egg is splitting and you're getting half of those chromosomes into what can be fertilized. And in the process of creating sperm, men are creating 1,500 sperm a second. And so their testes need energy for that entire production process. Having appropriate DNA is the low end of threshold of what needs to be normal inside your body. So especially as you get older, or if you have any other medical conditions or inflammatory diseases or anything else going on, CoQ10 is something that might help your mitochondria function a little better and more effectively and potentially improve egg quality, sperm quality. And in fact, CoQ10 has been shown to be helpful in studies looking at getting pregnant, pregnancy rates, looking at outcomes from IUI, IVF studies, looking at embryo development, looking at sperm count and quality. So definitely suggestive that it can be beneficial. Is it beneficial to everybody? Probably not. Do some people not need it? Sure. Is everybody's diet equal? No. So there's probably many different factors which would make CoQ10 beneficial for one person, but it is one of those medications that doesn't really have many side effects. a few drug interactions, so warfarin, a blood thinner, some high blood pressure medications. I never recommend somebody just takes a supplement without reviewing with their doctor other medications that they are on. You'll even see many prenatals have CoQ10 now. When it comes to fertility studies, doses that have been looked at for sperm are 200 mg a day or 400 or 600 mg a day for egg quality. I personally recommend to my patients, especially if they're having infertility, if they have low egg count, if they might have PCOS or endometriosis, that they take 200 3 times a day, so a total of 600 a day. And again, we are seeing some of this in prenatals, so you might not need to take anything additional. All right, I have another question, which is going to be a unique scenario, but I think it provides some good learning points. So again, this is not directed medical care. Your doctor knows your case the best, but we're going to summarize some of the situation so that people can understand. So this is a 32-year-old who has 2 kids and has been trying to get pregnant with one more child, and now has had 2 second trimester losses, had a loss at 15 weeks and a loss at 19 weeks, which were both genetically normal. Had testing done and was told, just bad luck, keep trying. Got another opinion and told there was some retained placental tissue and needs to have a hysteroscopy to take out scar tissue. Endocrinologist also said to consider doing Lovenox, progesterone, maybe IVF. And this patient is just asking, if I have no problem getting pregnant, do I really need to do IVF? Is that their recommendation, even with genetically normal losses? First of all, I'm so sorry for everything that you have been going through. I know how devastating it can be, especially to get that far along and to have these really terrible, sad, devastating outcomes. Of course, when we start thinking about second trimester pregnancy loss, the things that are top of our head are going to be genetic abnormalities and blood clotting disorders, such as antiphospholipid antibody syndrome or factor V Leiden, something that could impact that placental blood flow. If we've had history of preeclampsia or growth restriction, then that also makes me even more concerned that something could be going on in that realm. Now, why do some of these things? Why would clotting? Why is the placenta? We think a lot of issues might happen at the placental uterine interface. And of the whole story, some things that made me most worried is that now we're having retained scar tissue and having to undergo surgery now so that we can take out the retained products and clean up any scar tissue. That alone is quite common. It's not really rare after second trimester loss. Second trimester losses are hard. You often need a D&C procedure to get all of the placental fragments, and having that retained little tiny piece can cause really devastating scar inside the uterus. So I'm glad that you're already did a saline, found what was going on, and you're having surgery to fix it. How I always explain this to patients at this juncture is that your uterus can only go through so much. So many births, so many placentas, so many surgeries. And once you've gotten to the point where scarring is starting to develop, then we are running more risk by having repeated losses, because at some point we might develop Asherman syndrome or complete scarring of the uterus, even if we are able to intervene and take care of everything now. So this is a place where, even though these losses were normal, making sure that we're putting in genetically normal embryos in the future, top priority, and making sure we're really optimizing the uterine lining, the growth, the implantation, and controlling what we can. Nice thing about IVF cycles is, in addition to genetic testing, we can give blood thinners really specific to when you're conceiving, and higher doses of progesterone, and we can give steroids or antibiotics and things that might help even when you don't 100% know what's going on. There might be something underlying. I don't love relying on bad luck. And so to just try to get pregnant again naturally doesn't feel like you're changing that environment, and does feel like we might be placing our uterus at greater risk at this time. So even though you have gotten pregnant after these 2 really devastating outcomes, I agree. I would be in the camp of saying, let's do IVF. Let's know that we're putting the best embryo in the best environment, controlling all the scenarios that we can when we have this gut feeling and all these clues and red flags that something is wrong. Even if none of your tests are truly flagging positive, sometimes things can be very tough to diagnose, or levels have to be really high to get to a true positive. I like the plan that's in front of you. I know sometimes it can really be a mind game, but I'm proud of you for keeping on and for asking questions so that you can be as educated as you can in this stage of the game. All right, and this is going to be our last question from the newsletter. Again, if you'd like to sign up for the newsletter, nataliecrawfordmd.com/newsletter. We answer fertility questions there. We do special things. We're having some really exciting upcoming special events and things and recipes. And so just nataliecrawfordmd.com/newsletter. And if you'd like to ask other questions, that's on Instagram at nataliecrawfordmd on Mondays, or you can call 657-229-3672. All right, the last question is a few years ago, I started dealing with hirsutism, which, for those of you who don't know, is exceptional hair growth greater than what should normally happen. And my OBGYN said my labs were all fine, my levels don't indicate that it's from androgens, and said that it must be in the hair follicles. Is this treatable? How can I minimize it? I'm 26, I have regular periods, and I started having my periods at age 12. So when it comes to hirsutism, there's a few different things to know. Some people are just more hairy, whether it is genetic, whether it's your ethnicity. And so we always have to compare to what we feel like should be the norm. And we're definitely living in the era of a hairless society where nobody wants to have any hair whatsoever, which makes this harder. Another thing that can make this hard is many people are on birth control pills or some form of contraception, and that can often interfere with some of your blood work or your labs. So for example, if you're on the birth control pill, that can be a really great effective option for contraception, but the birth control pill is metabolized in the liver. And in the liver, one of the things that happens is the birth control pill upregulates the production of something called sex hormone binding globulin. And that might sound like a mouthful and like it's no big deal and something you don't have to worry about. But sex hormone binding globulin goes around your blood and it binds to some of your sex hormones. And what's super interesting about that is that if your sex hormones, like testosterone, are bound to sex hormone binding globulin, they can't go bind to the testosterone receptor. So they get locked in. They already have a partner, so they can't really go and make a difference somewhere else. So one thing that I see is that people have some hair growth, but they get put on the pill or they're on the pill and then they get their labs done and their androgens are low and they get told that it's not that. But you can still have continued hair growth. So an important thing in the lifespan of a hair follicle, wherever it is that once it's grown, you have new hair in a new place, that's not going to stop. No medication or treatment is going to stop it. The point of trying to lower androgens, if this is hirsutism related to androgens, is to make sure that you're not getting more new hairs, more hair popping up in new areas. For hair that's already there, you're going to have to use hair removal methods. So shaving, waxing, laser hair. So I'm a huge fan in these scenarios, especially if it's on your chest, your back, your face. That laser hair removal is one of the best because it actually is destroying that pigmented hair in the follicle so that those hairs aren't going to come back. Now, you're going to keep getting more though if your androgen's high or if you're not treating it. So some of the treatment modalities can be things like the birth control pill itself, if you're on it or not, spironolactone, which is a medication that lowers testosterone. Metformin can actually be helpful sometimes because similarly, it can improve insulin resistance and it can lower some of the ovarian testosterone production. And then losing weight if you're overweight because those fat cells can make hormones as well. An important distinction, and my doctor said my androgens are fine, is what did they check? Because we have to remember that androgens are made in the ovaries and from the adrenal glands. And certainly I've seen people misdiagnosed even with PCOS who truly had congenital adrenal hyperplasia, they had a tumor in their adrenal gland, they had something else going on. So you want to look, it's more than just testosterone. When you check testosterone, you want to check free and total levels. If you're on birth control pills, you know that's not really telling the full right now story. And that being on the pill might be preventing future new hairs, but they're not going to get rid of what's already there. You're going to need a more permanent hair removal method. And then when it comes to the adrenal glands, you're classically checking something called DHEAS and 17-hydroxyprogesterone or 17-OHP. These are helping you look at congenital adrenal hyperplasia or CAH, which is an inherited issue in your adrenal gland hormone production. Essentially, you tend to not make enough cortisol, but you overproduce these androgenic steroids, and DHEAS can actually be high if you have an adrenal gland tumor. Similarly with testosterone, you might have mildly higher levels than you normally see in women with things like PCOS, but levels above a certain level are highly concerning for an ovarian tumor that is making testosterone. And sometimes these can be so hard to see on ultrasound that there's some other diagnostic methods to try to get there. So there's levels of these that your care team should know about. A total testosterone level greater than 200 and a DHEAS level greater than 700 are highly concerning for tumors that you should go and investigate. And then the only way to really overcome that is to get it removed. So take-home messages: can't stop hairs that have already been made besides anything that's permanent, so permanent hair removal methods. You can try to prevent new growth of hair by stopping the androgen production if that is potentially a cause. And in order to understand that, you're going to need testosterone levels, DHEAS, and 17-OHP. And if all of your hormones are fine anyway, many people will still try birth control pills combined with spironolactone or one or the other to see if perhaps your androgen receptors are just more sensitive, and maybe that can help you prevent new hair growth. Overall, it can be hard. It's definitely better to get a game plan sooner than later before you get even more hair growth. All right, friends, these were fabulous questions. I loved going over them with you. Much variety, and I hope you learned something about your body today. As always, thanks so much for being here. You can ask your questions on Instagram on Monday at nataliecrawfordmd. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And if you want to call and leave a question, 657-229-3672. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.